Dr. Chekitaan, please.
Thank you. Thank you so much, Amitabh. So I'll just rush through my presentation. My topic is trump card using methotrexate to navigate tough uveitis scenarios. This is the brief outline, no financial disclosures. So methotrexate was first used to treat intraocular inflammation in 1963. US FDA approved for treatment of rheumatoid arthritis in 1988. It has two mechanisms of action. So it is the second action, which is the AICR transformylase inhibition, that causes the anti-inflammatory effect. The dose is as low as 7.5 milligram, can go to 25 milligram per week, can be given by all routes, per orally, subcutaneous, intramuscular, and intravit. Supplementation is with folic acid, 5 milligram per day. Full efficacy is reached in 6 to 8, rather I would say even up to 12 weeks. Usage tenure is 6 to 24 months at an effective dose. Tapering can be done after 3 to 12 months of therapy. Monitoring is with CBC LFT, preferably done every 6 to 8 weekly. Precise dosing based on the disease type, severity, compliance, and medical and social conditions and complications. Indications and responsiveness, you can see from this particular table that childhood chronic uveitis responds the best to methotrexate, followed by scleritis, then anterior uveitis, then intermediate uveitis, and panuveitis is among the lower responders. Very effective in OCP as well. Very effective in sarcoid uveitis. They say with steroids and methotrexate, sarcoid effectively melts away. The most common side effects are gastrointestinal and malaise. And bone marrow suppression follows and increased level of liver enzymes. That is when you have to reduce the dose. When do you add methotrexate? Uveitis, which is not controlled on corticosteroids alone. Maintenance of a suppression of uveitis requiring oral prednisolone more than 10 milligrams. That is the dose which becomes unsafe for a long-term use. So it has to be less than 10 mg if you want to continue steroids for a moderate term. Or patient developing intolerable side effects, as you can see this particular lady developing acne and moon face and brittle bones. Specific disease known to respond poorly to corticosteroids alone, like this fern petal leakage in a case of Behçet's disease. Disease is known to respond particularly well to methotrexate, which is a sarcoid vasculitis. You can see the candle wax drippings. Intolerance to other immunosuppressives like allergy to azathioprine and cyclosporine. Socioeconomic status, it's very pocket-friendly immunosuppressive. I just did a study in which I found out that methotrexate every day cost was rupees 11 per day, compared to azathioprine 155 milligram was 34 rupees per day, and mycophenolate mofetil was around 120 rupees per day. So this seems a very small figure, but if you continue it for 2 years, that is a substantial amount of money. So this is a case, a young boy, 20-year-old, presented with right eye decreased vision since many years, and left eye he was seeing a scotoma since 2 weeks. You can see a choroiditis patch invading the macula from the superior arcade. It is active on autofluorescence and also on fluorescein angiography. Investigations were positive for a ESR which was raised and a MEN2 which was positive. So it was diagnosed as presumed tuberculous serpiginous-like choroiditis, referred to a physician for ATT. After ATT was started, was given IVMP, 1 gram per day for 3 days with systemic steroids 1 milligram per kg, which was continued. However, the uveitis continued to progress. At this point of time, I added a posterior subtenon tricot. But even after that, you can see 3 weeks post all of this, PST, IVMP, systemic steroids, and ATT, it is still progressing, reaching very close to the fovea. At this point of time, we discussed with the internist, and at that point, repeated IVMP, 3 doses. And that is the time there was a sigh of relief and it started responding and healing. You can see the healing edge on autofluorescence here. And 6 weeks post that, we added methotrexate, and 6 months down the line, the disease was completely healed. This is another case of a recurrent multifocal choroiditis in a middle-aged female. She was taking steroids for the 3rd time and was on 30 milligram when she presented to us. So after starting methotrexate, 6 months, you can see that the lesions are healing on autofluorescence and color fundus. And we had acquired Optos by then, and you can see the great amount of extra information that the Optos is giving, and a beautiful autofluorescence. This is 11 months post methotrexate, which is a completely healed choroiditis. Methotrexate comes to the rescue in recurrent anterior and pediatric uveitis like HLA-B27 associated uveitis, which is the most frequent specific cause of uveitis in young adults. Mostly presents at acute anterior uveitis, can also present as intermediate and posterior uveitis, has concurrent systemic disease in a majority of patients, typically managed with steroids and cycloplegics, topical, Recurrences are although very common, and sometimes they can present as a fibrinoid reaction. So it's a very bad recurrence sometimes and has a cumulative effect. Methotrexate is the most commonly used systemic agent for treating these, and it has a triple advantage. It prevents recurrences, reduces severity, and addresses systemic disease. Pediatric chronic anterior uveitis is another challenging cases to manage. Uveitis management is challenging as children are usually asymptomatic and have complications right at presentation. Long-term use of topical steroids can cause cataract and glaucoma. Long-term systemic steroids can cause irreversible consequences on the skeletal and immune system. Once a week, methotrexate has become therapeutic agent of choice in children with JIA. In low doses, methotrexate is less toxic than most immunosuppressants, including corticosteroids. In a study, methotrexate therapy reduced topical steroid use from 6 times to 1 time a day, and steroid use from 18 milligrams to 2.8 milligrams a day. So that is a considerable reduction in steroid dosages and considered side effects. A randomized controlled trial comparing methotrexate to mycophenolate shows that 69% of the patients at 6 months were in remission compared to 47% with mycophenolate. Median time to success was, however, the quickest for mycophenolate and the slowest for methotrexate. Methotrexate is more effective and better tolerated than other immunosuppressive agents. Severe posterior or panuveitis is where they respond poorly to methotrexate, and prior use of any other immunosuppressive does not dull its effect. It is a known teratogen, however, so if patient is planning to conceive, at least 3 to 6 months, the patient should be off methotrexate. Intraocular methotrexate has been tried in uveitic macular edema in various conditions. However, it is the short half-life which actually is a demotivating factor. I've also used it in Behçet's disease with limited this thing. So it was the SIGHT study which proved that the usually commonly used immunosuppressives are safe. They do not cause cancer. And achieving a remission, the highest in these cases was cyclophosphamide, followed by mycophenolate, then methotrexate, and then azathioprine. So the take-home message is methotrexate is moderately effective at controlling moderately active cases of uveitis. It is pocket-friendly, and you should do a good clinical examination and imaging. IM route avoids gastric complications. My starting dose is 10 milligram weekly with escalation, not associated with an increased risk of malignancy. It is a known teratogen. Informed consent is a must for starting all immunosuppressives, and immunomodulation is a long-term commitment. Please educate your patient adequately. Thank you so much.